And you know from your anatomy that pancreas is divided into four regions: the head, the neck, the body, and the tail. And you can see that the common bile duct and the pancreatic duct, they unite together and then enter into the second part of the duodenum, which is called ampulla of water. And all these structures, the wall of the duodenum, the pancreas, and the common bile duct, they combine to form a periampullary region. Now, before starting this lecture, I would like to just explain that we will discuss pancreatic cancer, since the periampullary cancers also mimic the pancreatic cancer, only that the pancreatic cancer is has got more has got a bad worse prognosis than the other cancers. So we'll discuss pancreatic cancer in detail, and you can see that it is the fifth leading cause of cancer deaths. All the cancers, male and female, fifth leading cause of cancer deaths, and it has got a poor prognosis with 5 year survival of less than 3 years. It's such a deadly cancer. Now, most of the cancers of pancreas, they are derived from the exocrine portion. You know it already that pancreas is histologically divided into the endocrine portion and the exocrine portion. Although obviously the endocrine portion is much less than the whole exocrine portion, therefore most of the cancers derive from the exocrine portion of pancreas. Here is a picture of three gentlemen, and they are famous people. They were famous. They are all dead now. And do you think what is common among all three gentlemen? Two of them were the Hollywood personalities, and one was well known, the well-known scientist who developed iPhone. So the common thing among all three was that they all died from pancreatic cancer of one type or another. So you can see how deadly this disease is. If we see the clinical features, they you can see that the pain is one of the cause, and it tends to be dull epigastric pain which may radiate to the back, and usually it is very vague pain, uh, worse when patient lies supine. More than 50% of the patients with early pancreatic cancer have almost no pain or little pain. That's why the symptoms, they come late. That's why the when the cancer is diagnosed, it is already in an advanced stage, and that is one of the reasons why it kills a lot of people. Next thing is weight loss. 7 to 10 kg within few weeks may be there, and jaundice. And jaundice actually only appeared in case of the pancreatic cancer when the cancer is at the region of the head and the neck. Otherwise, if it is away from the common bile duct, then jaundice is a very late or may not be a symptom. Only when it compresses the common bile duct, the obstructive jaundice then takes place. More infrequently, the patient will present with pancreatitis, portal hypertension, sometimes gastrointestinal bleeding when that erodes into the duodenal area. Migratory thrombophlebitis, very rarely. It means it's the thrombophlebitis of the veins of the body in the migratory fashion. It starts, for example, in the axillary vein and then going down and then may go into the leg veins. So this is called migratory thrombophlebitis. and polyarthralgia means multiple pain in the multiple joints. If we talk about the risk factors, I think uh, nowadays this smoking is the biggest hazard, and it is twofold. It is found twofold in the smokers as compared to non-smokers. Diabetes again is one of the risk factors, and chronic pancreatitis, um, a low factor, a low risk factor, but it is definitely a risk factor. But as compared to smoking and diabetes, it is much less. So smoking is number one risk factor, I would say. Now, if we go for the investigations, obviously we have to diagnose it when the symptom patient comes with symptoms. So we have to diagnose it, and there are number of tests we have to perform in this case because of the poor symptomatology. Number one is liver function tests, and component of conjugated bilirubin is helpful in determining the obstructive nature of the jaundice. Another one is which is non-specific. This is tumor marker CA19-9, and since this is not very specific, this can be elevated in other type of GI tumors. So this is not very helpful for the diagnosis, although we can use it for the follow-up after the treatment. Whenever after the treatment this starts elevating, it means that the cancer has been recurring. So this is only helpful for the follow-up. Ultrasound scan, you see, is very commonly done investigation in other diseases as well. It is very easily available, non-invasive. That's why we do it so frequently in all type of abdominal symptoms. And this, I would say, is the first line imaging modality, and it detects dilated intrahepatic and extrahepatic ducts when they are actually blocking the ampulla of water, and usually confirms obstruction. Endoscopic retrograde cholangio pancreatography is the next step in evaluating jaundice patients, both investigative and in therapeutic in nature, because we not only diagnose, but also we can put in stents in order to open up the blocked common bile duct. Considered sensitive in about 90 to 97% of patients in the way of diagnosis. We can also take the brush cytologies, and it is to help out to see the malignant cells in those areas. But it is also associated with complications. First of all, the endoscopic ERCP may not is not done, cannot be done because of one reason or the other. So this is called technical failure. It may lead to pancreatitis. It may lead to perforation of the duodenum, bleeding. So these complications may occur. This is a ERCP is associated with uh, quite substantial complication rate. Now the CT scan can be used for diagnosis and to assess the tumor resectability. It shows the presence of a tumor mass in the region. Extra pancreatic involvement, for it means that tumor mass, how much it has invaded to the surrounding tissues. Vascular involvement, the vessels which are important, the pancreatic the artery and the vein, the supramesenteric artery and the vein, and it also shows the involvement of lymph nodes and the metastasis. So not only you can diagnose the tumor itself, but also you can stage the disease, how far spread the tumor is. Similarly, magnetic resonance imaging is also a very good investigation. Is considered equivalent to CT scan in assessing pancreatic cancer. The only drawback is that if uh, expensive, well, yes, as compared to CT scan, but also the metal implants, if they are present within the patient's body, then MRI become impossible because of the scattering of the image. Here we will discuss the role of angiography, selective angiography. Selective arterial injection of superior mesenteric arteries with venous phase studies has become is considered as the best in demonstrating vascular anatomy. We pass in a catheter up to the superior mesenteric artery and we inject with the contrast, and then we take the x-rays in different phases, the arterial phase and then the venous phase, and venous phase is the best to demonstrate the vascular anatomy. More than 75% of the patients with normal vessels on angiography means that the tumor is resectable. Since it is an invasive investigation, more and more centers are relying on the CT scan or the MRI scans rather than selective angiography. This is another investigation which is very helpful. It is called endoscopic ultrasound, and by the name you can understand that ultrasound done through an endoscope passed up to the area of duodenum, and images are taken in around that portion. It provides an excellent information about the resectability and local lymph node involvement. The only drawback is that sometimes it is difficult to differentiate whether this mass which the ultrasound has picked is a pancreatic cancer or just pancreatitis. Percutaneous fine needle aspiration. Uh, it can diagnose cancer in the patient who are not an operative candidate, and seeding of the tumor alongside the needle track was once thought to be a drawback, but practically speaking, these type of seedling never occur, and the patient on which this test is performed are really in an advanced stage, so it really doesn't matter whether seedling takes place because of his the patient's short life expectancy. Laparoscopy. Although special expertise is required, a diagnostic laparoscopy can be performed, and this leads to less unnecessary laparotomies. We can able to detect different type of metastases through laparoscopy, and we can stage the disease. PET scanning, positron emission tomography, a relatively recent modality. Very not very clear role is there, but for diagnosis. But this test is very good to detect the recurrence of the disease. This is not very well role is very well established for the diagnosis, but for the recurrence of the disease, this scanning is number one. Now, as we know that all the malignant tumors, wherever they exist in the body, before starting a treatment has to be staged, because the early stage tumors, uh, we go for the curative intent, and the advanced disease we go for the palliative intent. This is the general rule of all the malignancies. So staging of the disease is very important, whether it's a breast cancer or a pancreatic cancer. So, like most of the other tumors in the body, the pancreatic and the peripancreatic cancers are staged on the basis of T and M classification. So, therefore, tumor size matters in case of CA head of CA pancreas, where T1 are those tumors which are less than 2 centimeters, while if they are more than 2 centimeters, they are labeled as T2 tumors. Similarly, T3 and T4, the size does not matter in that case, and you can notice here that T3 tumors are those that extend beyond the pancreas but within the involvement of the celiac axis. You can see here the T3 tumors size is not mattered, but actually the extension to the surrounding tissues is mattered, while T4 tumors are those which involve the celiac axis or the superior mesenteric artery. You can see here the superior mesenteric artery, this red line, and the tumor is actually invaded into it, and then they are termed as irresectable because of the involvement of the vascular system of the pancreas. It becomes irresectable. Nodes, again the nodal status N0 when no regional nodes are involved, while N1 is the one where the regional lymph nodes are involved. For example, here is the tumor and the regional lymph nodes which are alongside the pancreas, they have been involved like that. So when the lymph node, the nearest lymph nodes to the tumor are involved, then it is called N1. And then the metastasis, the distant metastasis status, M0 when there is no metastasis anywhere, while M1 is one where the metastasis, the distant metastasis is present, for example, in the liver. You can see the tumor lies here in the body of the pancreas, and the metastasis has developed in the liver. Now, if we see how the anatomy and the surgical resectability of the tumor correlates, you can see that the lower end, when we see at the lower end of the spectrum where the resectability is at its best, the points are that there is no arterial or venous involvement, or when the tumor is involved attached to the surrounding adjacent organs, even that is resectable too. And at the opposite side, you can see when the arterial encasement, yani surrounding of the arterial or the vascular pedicle with the tumor, and the distant metastasis is the farthest this the farthest point where the irresectability becomes most eminent. the distant metastasis, and before that, arterial encasement. So, whenever these two things are apparent, the tumor becomes irresectable, and mostly palliation is the answer. Palliative treatment is the answer, like stenting. Now, when we come to after the stage, we have to see we have to see the natural history, how natural history of this disease, the overall survival in these type of patients. For all stages, the combined 1 year relative survival rate is 25%. Only 1/4 of the patients who develop this disease survive after beyond 1 year, and the 5 year survival is just 3%. For local disease, which is confined like T1, the 5 year survival is on average 20%. For locally advanced and for the metastatic disease, the median survival is just within months. You can see not even the years, just months, 6 to 10 months with treatment. The untreated metastatic disease has a median survival of 3 to 5 months. So, just by reviewing the overall survival, you can see how deadly this disease is. I would like to mention here that this is the overall survival of the pancreatic cancer. The periampullary has um, a better survival rate. For example, all those you can say that the survival rate of the periampullary carcinomas is 10 times better than the survival rate of carcinoma of the pancreas. Now, when we come to the treatment aspect, we can see here that the radical pancreatic resection is the answer to for the stage 1 and 2 diseases. You can see that stage 1 and 2 disease, where the disease is confined, it is not advanced, you have to do something which is more radical, so that you tend to eradicate the disease entirely. And in those patients where the tumor has been advanced, T3, T4, and the nodal status is advanced, here in the coming slide I will discuss where you have to do some conservative palliative procedures. You don't go for the curative intent because it is not possible. So Whipple's procedure, which is the classical procedure for stage 1 and 2 disease, which means you have to remove a segment of pancreas, the duodenum, the entire duodenum, and the distal part of the bile duct, in order to remove the entire disease. Then you have a second option depending upon the site of the tumor. Whipple's procedure is done where the head of the pancreas is involved, and elsewhere in the pancreas you have to do total pancreatectomy. For example, in the body, if the tumor is in the body of the pancreas, you have to remove the whole pancreas, or the distal pancreas if the tumor lies in the tail of the pancreas. So these are the procedures for curative intent. Radical pancreatic resection with postoperative chemotherapy is adjuvant chemotherapy is also indicated with 5-fluorouracil or gemcitabine. These are the two chemotherapeutic agents which are also adjuvantly given to these patients with benefit in the survival. Here is a diagrammatic representation of the resected area for Whipple's, and you can see you remove the distal portion of the bile duct, the duodenum up to here, and you have to make 3 anastomosis, one with the bile duct, make 3 anastomosis with the jejunum, one with the common bile duct, other with the pancreatic duct here you can see, and the third one with the stomach. The stomach, bile duct and pancreas, 3 anastomosis are then made so that to ensure the drainage of bile, pancreas and the stomach contents. So this is the end result of Whipple's procedure for CA head of pancreas. You can see in this diagram that there is a CA here, and you have removed these portions. You are end up with doing 3 anastomosis. So Whipple's procedure. Here is a list of various studies done in various times with different type adjuvant treatment with cancer therapeutic with chemotherapeutic agents. Different studies were done, and with different number of patients, and you can see the largest number of patients aspect study, and these 2 chemotherapeutic agents were used. And you can see here with the resection and the adjuvant therapy, the median survival was 23 months, and not much improvement in any other study as well. You can see how deadly this tumor is. 16.9 months, 21.6 months, so on and so forth. So this is a disease with high mortality. So in summary, it's a 5th leading cause of death in the world of all the cancers, and it has a high mortality. Only 5% of the people survive for 5 years. Usually non-curative state. Usually they are diagnosed in an advanced stage. when they are first time the patient comes to you, they are already in an advanced stage. CT scan, the contrast CT scan or the MRI scan are the best investigations for the diagnosis and staging. Whipple's procedure is the curative procedure in cases, or the total pancreatectomy. Bypass or stenting is done for the palliation in advanced disease. So technically, when we come to the stage 3, technically unresectable because of the local vascular involvement, and palliation is the method of choice, either surgical or endoscopic, and usually they are incurable, and 30% of patients presenting with stage 3 disease die with evidence of distant metastasis as well. So we have already discussed that mostly palliative treatment in the advanced stage, and there are clinical trials of different type of medication. I've already mentioned in the previous slides. There are very dismal median survival, even if with the treatment and the adjuvant treatment with the chemotherapeutic agents. So lastly, I would like to present to you a multiple choice question so that you may answer it. The question is, which feature is the least common found in the CA head of pancreas? Which clinical feature is found least common in the carcinoma head of pancreas? And there are 5 options, and you have to choose which is the best option in this multiple choice question. abdominal pain, weight loss, malabsorption, jaundice, or palpable non-tender gallbladder. So among these five options, which is the least common in case of CA head of pancreas? Please try to answer this, and at the end of this presentation I will answer that as well. So I hope you must have answered which is the least common in the case of CA head of pancreas. Thank you very much. And the answer to this is malabsorption. Malabsorption is the least common uh, clinical feature in case of CA head of pancreas. Thank you very much.